Good morning and welcome to another edition of This Week in Digital Health. We are joined today by Neill Dunwoody of SPYRT. Neill, how are you?
Good. I'm good. Very good. Yourself, Mike?
I'm good. So you guys have been busy. What's been going on?
Yeah. So we're trying to become the front door to healthcare. It's not an easy job, but we're trying to make it as easy and as accessible as possible for people to get either the ability to book and manage their appointments or reschedule, and then particularly ask operational questions around any procedures they may be going for. Um, So we took it on ourselves to try build an AI, which we call ASA, and which is the Hebrew for health. Um, Basically in a way that's easy for anybody to use. So from 18-year-old all the way up to a 90-year-old, they have no app to download, no website to visit. Our AI lives on top of instant messaging services. Over here in Europe, predominantly within WhatsApp, because it has the highest encatchment rate of about 98% across Europe. And then in the US, it'll be in Pockets, Messenger, iMessage, Messenger, RMS. So depending on the region which has the highest coverage of that messenger. So it basically means like you and I could have a conversation now across Messenger, and it would be the exact same as a person having a conversation with our medical AI, ASA, and it can communicate in one of 144 languages. So it's as easy as that.
Let me do this. Let me step back a little bit and let me sort of
Yeah.
define the problem. So what's your understanding of what's the percentage of missed appointments?
So several examples. So I'm in Ireland, right, to give you a rough example. So in Ireland, in outpatient appointments last year, there was 3.5 million appointments. 517,000 patients didn't turn up, so 15% just within outpatients didn't turn up. That's higher once you go into, say, different procedural appointments, dental appointments, GP appointments, physio appointments, you name it across the healthcare gambit, that increases. But in the US market, say, for example, I can give you a figure. So annually in the US, there's about $150 billion are lost on no-shows, all right? And in the UK, it's about 1.8 billion pounds in no-shows. Now, it's a lot smaller in the US, but again, it's a smaller market, as well as the fact that healthcare in the US is on average about 10x more expensive than over here in mainland Europe.
Yeah, so I would agree. The number that we typically see is about 150 billion, which is just astronomical, right?
Yeah.
The amount of money that's being lost. And what that equates to is for every missed appointment, the care center loses about $300 when the patient doesn't show up. So I just wanted to sort of frame this conversation around the problem statement, which is this is, I mean, healthcare is expensive, and these are the types of things that drive up the cost of healthcare. And I mean, I think the number is somewhere around between 20 and 25% of appointments are missed,
Yeah.
right? Somewhere in that neighborhood.
Mm-hmm.
So, which equates to this huge number and, is a very expensive aspect to healthcare. So when we're, constantly focused on providing value-based care and driving down costs, it's really about one of the key components, I think, is about, dealing with these missed appointments. And I think that's where you guys come in, if I'm not
Yeah,
misunderstanding
yeah.
the nature of what you do.
So we come in on 2 points. One is obviously to predict the no-shows, but we take it further than that. So we use behavioral science and linguistics to change the outcome. So to get the person to either turn up to the appointment or reschedule or cancel the appointment so somebody else can take the slot. But on the other side, so to give you an example, we're running a cervical cancer pilot in the UK, right? So on average, it takes one person 30 hours to book in 25 people to make sure 25 people turn up for a cervical cancer appointment. We can literally do that in minutes. So we're giving about 30 hours back to the clinical admin. So the other thing is in the US, there's over $1 trillion a year spent on administrative costs within the health service, right? So our thing is, if you could imagine, and most of that is spent on facing patients, dealing with patients, patients who are underserved, patients who may need more, who may not be digitally savvy or may not have the ability to answer or reschedule appointments. So we would try to take over 80 to 85% of that. So freeing up 15 to 20% off that time to get back to the administrators. So really to take them away from being seen as gatekeepers to make them facilitators of care. So they help in the care pathway. So, and again, bringing down those overall costs. And that's what drives it. And I suppose that's the other thing where we found from what we're doing, why medical admin or clinical admin, people have an outline persona of that person as, and they're not happy in their job. They don't like doing what they're doing. They're just doing it for a paycheck. And to be honest, it grates. Like if you're having to answer the same question 100 times a week, oh, how do I get here? Is there parking? Things like that. And you're not really helping anyone in the medical sense. You're just telling them there is parking. But ASA can do all of that. And then in Predictor, like we have social healthcare systems over here, and we do have private to smaller point. But in the US, our thing would be also the ability for a person to pay a copay or a payment through a secure link that we provide. So we're not taking them off anywhere. So, and eventually the whole point would be, unfortunately, as we're all aware, as we get older, we have older parents and older relatives. It never tends to
we're
just
just old.
yes. It never tends to just be one ailment. They all come with a multitude of ailments, with a multitude of schedules and a multitude of appointments. The difference is we'll have the ability to manage all those appointments. I don't know about in the US, but over here, say my parents might get called for, say, for example, a heart appointment one day, and my mum had cancer, so she'd be called for a follow-up the next week or whatever. But it's not where I live on the border, and predominantly the hospital everybody has to go to here is in Dublin. So they have to travel just over 2 hours to get to an appointment. And it might be go on a Tuesday to one, go on a Wednesday to another, go on to another on a Friday. Or instead of us being able to go, well, these appointments are all coming up, could we not all have them in the one day? So they're only having to travel down, do the full day of appointments, or can we not spread those out over a couple of weeks? Take off the burden of the travel and everything.
So what I can tell you in the US, and I can just tell you from personal experience is, I get text reminders for any upcoming appointments from me or my family, and we typically will also get a phone call. So administrative, like you said, this is a big time sink. But I guess the added aspect of SPYRT is this sort of prediction of who's most likely to miss their appointment based on your AI model. How does that increase? What is your expectation as to how this benefits the show rate, or the actual getting people to these appointments? How does this improve that?
So effectively what we found doing the pilots that we're doing, right? The biggest reason for no-shows is the inability of somebody to reschedule. They can't get through to anyone on the phone, right? So they're ringing and the phone rings off the hook, or it's engaged and they can't get through. So it just gets to the point where they get frustrated and they just go, look, that's it, I've done, I've tried. Their problem if I don't turn up. Right. So that's one reason, right? The other thing is that people get a phone call, right? Or they get a text and they may get a clinical administrator. They have a allotted amount of time that they have to dedicate to each call. So they may not be able to answer all the questions that person may have, right? So ASA can do all of that, right? So we can do all of that. The other thing is, say, for example, somebody goes for an MRI, we can send out the pre-questionnaire. They can have it filled in, done, sent into the clinic, so the clinic can be prepped to say, yes, this person has no piece of metal in their body, so they can go to an MRI, or no, we have to plan to do something else to do that scan, right? So we're trying to make it as easy as possible in that regards. The other thing is ASA can detect hesitancy, right, in regards to your answers or full understanding of your answer, and it can simplify the questions asked or simplify the answers that you can understand it better, right? And I suppose the other side is if you're say, for example, if you're a caregiver or a family member who's looking after somebody else, that'll be your kids, your parents, an aunt, or whatever. We have a group functionality, so somebody else can control all your appointments. And the other thing, it's not like a lot of the other services where they send you a text, right? And there might be a yes, no answer, or you click on a link and visit a portal or a platform and you fill in your details and you book your appointment or whatever. The difference is everything happens on that channel, right? So just on that thread, you're not going off anywhere else, right? So you can ask all the questions you have or all the questions you want. We will keep sending you reminders. We'll check in with you every couple of weeks. If it's a couple of weeks out from your appointment, we'll send you reminders every couple of weeks. So we'll check in and see how you're doing. If it's a couple of days out, we check. And what we found is that 25% of people, if they answer yes to a question, are more likely to adhere to that answer, right? So we try to keep you engaged. So that's what a lot of these other tech services don't have. They don't keep you engaged, right? They just send you a message and that's it, right? And also sending that message is considerably more expensive, right, of a service to be used, right? So like one thread for us, which will be an entire conversation over a number of days, will only be about 2.6 cents, right? So that's relatively cheap compared to a couple of dollars. So that's the one side, and I suppose the other side is, look, we live in a world now where it's multi-racial, multi-generational. People have different understandings of different things. I suppose the one thing with ASA, it will detect. But say, for example, most healthcare societies, the first language of choice generally tends to be English, right? Mm-hmm. But it will detect whether you're English, Spanish, German, Latino, whatever, and it will switch to the language that you ask it to switch to. As well as we found in one of our pilots that there's a high level of illiteracy. So we can actually send recorded voice notes in that person's language, say in Bangladeshi or Urdu, and then they can respond with a recorded note in their language, and our system will understand it.
And how many languages do you support?
144 at the minute. That will keep growing, okay, depending on the demand. I suppose the other thing is that for the minute we're concentrating on that oncology care pathway because we feel that's where we can have the biggest hit rate, because look, everybody hears numbers of 1 in 2 people who have cancer in their lifetime. Say in the US alone, cancer spending in the US is going to treble over the next 3 to 4 years, way up into the high billions. But the thing is, if we can catch people early enough and get them to turn up, there is a bigger chance that, one, hopefully they don't have cancer and they can be ruled out, or if they do, we catch them early enough, they go into that oncology care pathway early, right? That hopefully will be able to save their lives. But on the other side, the cost burden comes down, because the further you're into it, obviously the harder the treatments, the more drugs are having to be used, the more appointments are needed, so it becomes more expensive. So
take me back a little bit. Tell me a little bit about SPYRT. Like, so when are you the founder?
So I'm one of the founders. There's 4 of us. So there's myself, there's Dara Donahue, who's the CEO, and we actually grew up together. We're friends for the past 40 years. And then Paul, who's based in the UK, and Sean. So Paul's our CFO and Sean's our CTO. So Sean's the tech genius.
So when did you guys begin this process?
So March 21 is when we started. And we've learned a lot. So initially it would have came out of frustration of, we would have been at the height of the pandemic, right? And there was a lot of frustration around, I can't get a GP appointment, I can't get a medical appointment. Could you imagine if you could go simply message your GP and an AI would go, the doctor has a free slot now, do we want to book you in, right? And that was the initial thing. And what we learned over time was that GPs actually want no-shows, right, in certain clinics, or doctors, right? Because that gives them the time to concentrate on either patients whose appointments go over or run over due to whatever severe the case may be, as well as a lot of admin and everything else that goes along with that, right? So we tweaked and we changed and we looked at the care pathway, and what we found is 2 areas were really prevalent for no-shows, right? And one was screening services, so cervical, bowel, lung, prostate. So a number of these areas were very high no-show rates. And then the other side were diagnostics. So MRIs, PET CTs, CAT scans, there was a high amount. And even one of our advisors, who's a very, very senior cardiologist in the US, he was able to show us that there was a 25% no-show rate for a heart transplant.
Really?
Right. So things were staggering. So it kind of grew from there. And at the start, I'm the type of person that would be a big fan of Richard Branson, and I've always said if I can't do something, pretend I can, and then figure it out on the way through. So we applied for GE Edison, which is the biggest healthcare accelerator in the world,
Okay.
and we got in. And we worked with GE and Wyra, which is O2 Telefonica from Spain, and we secured a pilot with them, a large MRI pilot with a large private diagnostics company who has to remain nameless for the minute. With them, but our thing was, as friends initially, right? We wanted either to be able to offer people the ability on an easy way, because we'd seen the NHS app fail. We've seen an app that they launched in Ireland. There's been apps in the US like Babylon and everything else that have failed. Right? They didn't get buy-in. The big reason they didn't get buy-in is nobody wants another app to download or another website to visit when you could just simply text, "Can I have an appointment?" or "Can I reschedule?" And that's why it lives on WhatsApp. And it was a lot of hard work. So people say you've been at it now for just over 3 years. About a year of that was the actual building the tech, which most people would think, and the AI and the RAG model, which most people would think was the hard part. It wasn't. It was the compliance, the regulatory parts. So we obviously, our first large pilot is within the NHS in the UK, and we actually had to change government policy to be the first person ever to use WhatsApp and a generative AI for scheduling. So we're the first ever to implement both of those into the NHS. So that took a lot of work, right? So, and that was predominantly calls with compliance people, legal people, cybersecurity, but we're now getting there.
And what's the funding journey been like? Tell me about that.
So I suppose if I go back to where I came from, so I led sourcing strategy and intelligence for United Health everywhere outside of the US, right? So I had a good understanding, and I was particularly focused on Optum, so their technology side. So I had a good understanding how their technology business and everything worked, and how hard it was to get compliance. And then obviously knew Optum Ventures. I got headhunted out of Optum or United Health to join Ireland's largest VC, a company called Elkstone. So I was a partner there, and I knew how hard it was for healthcare companies to get funding, right? Because it's very hard to get in. It's a slow sales cycle. It's hugely compliant driven. And this was pre-pandemic, right? So they didn't adopt digital tech as quick as, say, other industries. Then the pandemic happened, right? Then everybody was adopting digital tech within health for COVID tracking, COVID apps, COVID results, you name it, virtual appointments, Zoom. So it was the perfect time. If we were going to strike, we'd strike now and we'd build something. But knowing and understanding how the likes of an Optum worked, it was, look, guys, we should bootstrap this for now. Because if we get in and we prove it works within something like the NHS, and the NHS is kind of seen as the pearl of kind of healthcare services, even though parts of it are broken and some of it doesn't work, but effectively it's probably one of the better ones. So if we could get in,
and it has the greatest reach, right?
Yeah. So as well as the fact that it's lots of independent trusts, so you can go in, do well in one, then develop another business relationship in another one. Instead of, if you go to, say, the Irish healthcare system, which would be the Department of Health or HSE, you would have one overall arching contract. Whereas the NHS, you'd have lots of different contracts.
But that gives you an opportunity to get in, like versus trying to take on the whole system at once, right?
Yeah, it's the same analogy as in like eating a whale. We just take it in bites instead of just going in and trying to take a large chunk. Effectively, my reasoning and our reasoning behind that is that if we can go in and we prove it, right, we're sort of, to paraphrase the pun, we're like a virus. Once we're in, and it's not about whether the clinics really love using it, but we built our dashboard to be easy to use and anyone can use it. But if the patients get used to it, and the simple fact we built it on WhatsApp here is because WhatsApp is actually taking over Messenger and messaging, right? It's most people, like I can't even remember the last time I actually physically sent a text on Messenger or made a phone call on the actual call app on my iPhone, right? It's literally all WhatsApp. So because you
Yeah,
have the
all the
free,
people that call me are spam. So it's like, yeah, when my
yeah,
phone
but
rings,
it's the
it's like,
same here. Yeah, so like it's either Telegram or WhatsApp. My WhatsApp is probably the most secure,
mm,
because and it is growing in the US. I think it's at 200 something million users in the US in the past 3 years. So like it Meta is predominantly taking over everything, right? So but I feel bootstrapping first. It's hard work. Um, you're using your own money. We brought in some investment from certain angel investors and advisors who we wanted to get in, be part of our advisory board to help open doors for us, which has worked. And so, like even last 2 weeks ago, we won the Pitch Fest at Hinds in Rome, right?
congratulations.
And we thank you, and we were the smallest company in it. Like the guys that we went up against in our final had had a huge revenue in the millions, had offices in New York, offices in Israel, and they just raised a large series, right? So, where we never raised any. So, like it was just the fact that look, these guys are building something that sounds simple that anybody can use, but
Mm.
we're not trying to rewrite the wheel. We're just trying to build an AI, but use existing tech, whether it's Messenger, RCS, or WhatsApp, to make people's life easier, right? And it's and you can see it because I see it in other businesses I'm involved in. They've dropped Messenger, they've dropped email. Now they're corresponding to their customers with a WhatsApp.
So, you mentioned that, a little earlier in the conversation, you mentioned that the physicians actually like the no-shows because that gives them more room, right? So
Yeah.
who do you go to? So they're not embracing this, right? So do you go to the
Well, they are for certain things. So
okay.
over here, say for example in the UK and in Ireland, right? So we say cervical cancer, lung screening, those type of screening services will be handled by GPs, right, predominantly, right? So now you have ICSs and different larger clinics that will do larger populations or larger population groups. But in Ireland, right, over here and in parts of the UK, predominantly cervical cancer bowel screening is done by GPs. But the difference being is that it's not like you ringing up, look, I've got a cough or I'm feeling ill or whatever for that appointment. It's already a certified appointment that's going to happen. You've been referred for that appointment.
Hmm.
They're the ones that just happen to be doing the appointment, but they have the overall cost because they have to get a room ready. They generally either have to have a male or female nurse on site, right? They generally have to contract them in for the day, right? The whole setup and everything else that goes around with that, the administration cost that goes along with that. And over here, they're paid to do a percentage of these appointments. And if they don't hit a certain marker, then they don't get paid.
Hmm.
So they're losing money by not doing them. So in that regards, they'll embrace it. They won't embrace it for the day-to-day GP service, right? But anything around screening, they'll adopt it. And then predominantly clinics or hospitals will adopt it uh, for like diagnostics, like MRI, CAT scan, X-rays, those type of appointments, and then any other kind of screening or large public screening appointments.
I
And
got
that's
to think
initially,
that, like, yeah, I was gonna say, I got to think like the healthcare systems, embrace it from a cost factor, right? Like it's just,
yeah,
it saves them money.
yeah,
Those missed appointments, don't generate revenue, or if they do, they're, the patient's unhappy because they're getting billed, and they're going to dispute it because they didn't show up, but they're still
yeah,
obligated to pay the bill, those types of problems. So I would think the healthcare systems embrace it from, the ROI of it. And yet,
Yeah,
the actual care providers, this is about, this is a value-based care model, right? Where maybe you get in early, like you said, so for early detection, we know that one of the biggest problems in healthcare is adherence. So getting them to show up at the appointment, getting them to do the follow-up, getting them to go to all the tests, because like you said, you spoke about your parents where, this isn't usually a single appointment that we're talking about. This is a series of appointments that are very time consuming, that require travel. So, to make it more efficient, obviously, it results in a better patient experience
yeah.
if
Like
they can.
it goes different things. So there's always maybe different. It's different in the US, but over here there's a cost, a factor, particularly if we start people are over 65 or if people are on social welfare, where they may need to have transport to an appointment. They may need to take a day out of work, or they may not be working, but they need to take an entire day to travel to get to that one appointment, right? So there's a knock-on cost to all the other public services that fall outside of
Hmm.
health. So it keeps steamrolling. The other thing is with our system, we're looking at things like waiting well, where about 3 in every 10 patients that turn up to an A&E or an emergency department actually do not need to be there, right?
Hmm.
They can either go to a GP or their pharmacist, a doctor or a pharmacist, right? And they can resolve their issue, right? So our thing is, you can imagine if you go into an A&E, you're simply triaged. The triage nurse or doctor or whoever may do it will go, look, you go home, but we send you a notification over WhatsApp if the A&E quietens down as there's less people coming in, or we have availability for somebody to come in and see you, right? So trying to free up A&E space is critical as well as the ability to, for example, I know in the US, and I know a couple of people over there who, for example, are going to have a hip operation or knee operation or something from playing football or whatever's happened to them, and they're on a list. So our whole thing is we will put you on a list, and as a slot may free up, as somebody may cancel or reschedule, we'll send out a messenger saying, "Are you available, Mike, to turn up tomorrow or the day after for this procedure? Yes or no?" Right. So, and we'll give you then all the information to prepare you for that procedure. So we're trying to cut away at waiting lists. Like to give you an example, in the UK, there's 7 million people, over 7 million people on waiting lists for appointments, right? And if we can chip away at even 10% of those, right, we free up millions and millions of pounds within that healthcare system, right? So that's what we're trying to do. We're trying to make it's the same as any problem or any bottleneck. It always starts at the start, right? So if we can free up that bottleneck, then everything else within the healthcare system should start to free up, and people will get seen quicker and will get seen on time.
So what are the next steps for you? You've recently you won the pitch contest. You've been through the accelerator, you've been bootstrapping. What do you see in the next 6 to 12 months? What are your primary KPIs? What's your
Yeah.
focus for the next 12 months or so?
Yeah, so we have a couple of different things on the horizon. So one thing was we're publishing a paper with the University of Surrey in regards to the trials that we're doing. And that will go into not just the no-show, but also the behavioral and the linguistics side of it, right? So RESs or AI is called, and how we're using that to get people to adhere to their appointments. That's the one thing. The next phase is obviously, look, I'm going to say what every startup over here generally says. It's we need to get to the US. So that's where you grow your market, right? We're already in talks with Blue Sheep Blue Cross in regards to pilots in Tennessee and Pennsylvania potentially. So that's a big piece. We've gone through our DTAC. We're going through HIPAA compliance at the minute. So that's one thing. Where we started the ball rolling in regards to integrating into Epic, right? So Epic is obviously huge in the US, not as
Yeah.
big over here.
Yeah, but
It was
they're the
actually
primary here.
yeah,
Yeah.
yeah.
If you're going to be
So
in the US market, you have to be on Epic, more or less.
yeah, yeah. So they've just rolled out across all of Northern Ireland, and it's the first time in Europe that one EHR primary care system has been used by one population. The problem is in Ireland and particularly the UK, it's fractured. So you might have, predominantly in the UK, it's EMIS, which is owned by Optum. But then you have Palantir and you have TSS and you have Cerner. So, and Epic in certain places, right? So they're all over the place. So there's no one system that collates them all, which tends to be more prevalent in the US. So if we get into the US, we're also in a conglomerate with SERMAS in Madrid, which is the largest public health service body in Spain. And we're looking at doing a pilot there in regards to digestive appointments, so around colonoscopies, endoscopies, things like that, because that has a very high no-show rate of about 25 to 30%. And then we're also in just started in trying to do a cross-border thing between Northern Ireland and the Republic of Ireland around scheduling and appointments. But our main focus will be the US, I suppose, over the next 12 to 24 months, trying to grow within the US. And I suppose it's different than here because, again, we're a socialist healthcare system and it's all about saving money and the economics of that. Predominantly what we find in the US from speaking to a number of the large healthcare providers, whether it's the hospital groups or the providers like the United Health or Elevance or Blue Shield, Blue Cross, or whoever it might be, their big thing is their star rating. So the patient experience, how is the patient going to use this?
Experience.
So we factored that in to a point where we want this to be as seamless as possible for a patient to book, reschedule, or manage all their appointments. Ask any operational question around that. Maybe, how do I get there? Can you send me directions? Is there parking? How do I pay for parking? Can I get an Uber? Can I get a lift? Can I get a train? Can I bring a friend? What's the cost? How long will it take? Those kind of questions. Any pertinent medical questions. And this is where we keep the clinical admin in the loop. It's flagged on the dashboard, and then they can take over on those questions. And so that's what we're trying to do with that, as well as offering the capability for once they've had their appointment for follow-up, right? Where it might be, hi Mike, we want you to come in so we can talk about your results. So it'll all go out over the one system, right? So just trying to keep people to adhere. It's not even to adhere to the appointments, adhere to the one system to book everything.
So you talked about, one of the primary pain points earlier on is the ability to reschedule. So how do you facilitate that?
Yeah, so we obviously, so in the UK we're plugged into EMIS, right, for the pilots, for the stuff we do with the NHS. So there's obviously two calendars. So the calendar we have is basically flows in from they're referred, the lady's referred for cervical cancer screening appointment. It hits EMIS. EMIS then flags it to us. We then contact the patient, and the patient we can start to ask, "Hi, Nadia, you've been called for cervical cancer screening. Is there a day and a time that suits you?" So we try to engage them to see, for them to engage and go, "Well, this day suits me at this time, this week, or this month," right? And then if that time doesn't suit, then we will give them times as close as possible to that time that suits, right? On the other end of that, if let's say Nadia goes in a week later, she goes, "Unfortunately, my boss won't give me the time off, or my child's sick, or I can't make it, or something's come up," you can simply message ASA, "Hi ASA, unfortunately, something's come up. I can't make that appointment. Can I reschedule or cancel?" Right? Now, we want them to reschedule more so than cancel. If they cancel, then we book somebody else into that slot. But to reschedule, and we go, these other times are available to you. Do you want to book one of these? Right? And we'll even say, do you want to come back to us, check with your boss or check with whatever, your calendar, to see, can you make that date? Then come back to us when we book you into that slot. So that's what we're trying to do. We're trying to make it as easy as possible, but for them to book the time, the day that suits them. Because if they book themselves, they're more likely to adhere to and come to the appointment instead of just being given an appointment. There's the date and time we expect you to be there.
And, I may have asked this, but I'll risk asking it again. What do you think, the improvement is? Like, so can you take 25 to 30% no-show rate and drop it down to what? Like, is there like something that you think you can target as, to demonstrate the improvement using the system?
We, like, to be conservative, we'd like to drop it down to at least 10%, right? And there's a kind of there's also that kind of a window, right, where something's happened within certain appointments, where an appointment will be running late, or the doctor is running late, or they're delayed on some nurse is delayed on something, or you wouldn't know what happens. So it's always good to have that kind of a leeway of potentially where something may happen that's out of their control. And the same, we're never going to get it to zero. That's being completely honest, right? But I think 10%, and it also depends in the area, right? There's certain, say for example, parts of the NHS and the trust we're talking to at the minute has an 80% no-show rate, right? So which is astronomical, right? So if we could get that down to even 50%, that's a massive difference. And again, that comes down to the services that are provided, as in the patient can't get through to anybody on the phone, right? Because you can call it 8:30 to 9 o'clock or 1:30 to 2 o'clock, but you only have those two sections of 30-minute windows when everybody else is calling, not just for cervical cancer screening appointments, for every other type of appointment. Or I need to refill a prescription, or I'm looking for results, or I need to get bloods done, right? So you're competing against a menagerie of lots of different appointments. So that's the one thing. That's how we know we'll get it down, because we're giving the ability to reschedule. The other thing is we take a look at, there's 7 factors, but there's 3 key factors, right? One is the ability to reschedule, right? Or cancel an appointment, right? 2 is the socioeconomic background. So where are they from, right? Is there a cost associated with this, or is there travel, which will have a cost associated to it? So can we bring that down? Can we move it somewhere closer to them? Is there a bus service or free bus service or something that can be provided? And then age, right? So what we found is that most women are over the age of 21 in the UK, or 23 in Ireland, that are called for cervical cancer screening. Most of them feel fit and healthy, so they don't bother turning up, right? And our job is then to educate them why they need to turn up, right? And yes, it can do that. So that's that side. But I suppose, and it'll be the same in the US, right? But also in the US, because you have, and I know this from working in United Health, 78% of people do not actually know or understand what their health insurance entitles them to, right? So we can be used to go, hi, this is Mike. Let's say, for example, you're with Blue Shield, Blue Cross. You can log in, say, I'm Blue Cross Blue Shield. This is the plan I'm on. My doctor is referring me to have a MRI of my shoulder. What am I entitled to? And then we'll be able to go, well, these are the different services. These are the different clinics. If you're willing to wait, it'll cost less. If you want an immediate appointment, it's going to cost more. And these are the things that you're entitled to, right? And it's being able to educate a person to go, well, I know what I'm entitled to, right? I know what I can go and have done, as well as the fact that I've seen it, right? It's the same as I worked in recruitment for years. If I can tell a person effectively, if somebody asks me to find a financial director for them, well, it's going to take me 3 to 4 months, instead of going, yeah, I'll get them for you, but not giving them a timeline as when I'm going to get them. You're better off saying, look, Mike, we won't have an appointment for you for at least 3 months, but we'll add you to this wait list. And if a cancellation comes in, we'll notify you and we put you come in earlier. Or if you're willing to pay a higher copay and go a couple of states over, a couple of towns over, you can go and have it done next week. Right. So
I think that transparency is tremendously important, right? Because the big fear is you go into the doctor and you don't know what the bill is going to be when you walk out. So in the US in particular, there's been a very big push on transparency and billing, so that patients know going into it, this is what it's going to cost you. This is your portion of it, so that they can either financially manage that or make some decisions around that. But this idea of the surprise bill hopefully is something that we're addressing seriously, so that no one walks away with like, oh my God, how did that happen? Because we're talking about serious health conditions, and the last thing you need is this giant bill that you weren't expecting, on top of the other troubles that you're, just from the nature of why you're seeking these appointments. So absolutely, in the US, we're definitely focused on transparency when it comes to billing. And that is all part of the patient experience. And in the US, because there's, we have these healthcare plans, which means you have the opportunity in many cases to go to several different places. And obviously what's going to drive patient experience, part of that is going to be billing, and transparency, because, nothing is going to, cause detriment to the healthcare experience or the patient experience like a really high bill that you weren't expecting.
Yeah. There's that, but there's also the overall, if we take into account, if we can make a dent in one, the no-shows, and one, the overall all administrative cost of healthcare, if we can bring that down, the savings then can be spent to lower cost of services that are provided, right? So in certain areas. So and I think, look, we don't know, everybody in Ireland and everybody in the UK bitches and moans about their healthcare service. But
That's
at the end of
everywhere.
the day, yeah, but at the end of the day, if it doesn't matter if you can afford it or you can't afford it, you will eventually be seen, right? So, and like, there is a party. You have private and you have public, but in my experience, I have private health, right? But sometimes public health is actually faster than private, because there's certain services that they can provide that people aren't going for, that more might be going in private. And it swings and roundabouts. But I think the overall thing is that we're trying to make it as easy for you as a patient to access it, and as easy as, say, clinical admin or somebody's managing appointments and scheduling and managing that administrative side of health, for them to use it. And down to the little things that we've built in, that if you can say, if you suddenly feel unwell, I've got chest pain, or I'm feeling suicidal, or I've fallen and I can't get up, you can simply WhatsApp ISA and it'll alert your clinic, right? So that effectively they can take over, they can take response, they can call an ambulance, and they can get somebody out to you, right? So that's what we want it to be. I call it PEAS, patient experience as a service, but that's what we holistically want to be. And then further down the field, we want to get into voice with Alexa, where somebody can speak to an AI and manage and book all their appointments that way and get all the information they want through that. But I suppose the other thing is, most people are wary of ChatGPT or Perplexity or Llama or any of these other AIs. We train our models on AI, but the person interrogates is a RAG model. So we take the data directly from the healthcare provider, say for the cervical cancer screening pilot, which comes directly from the NHS, as well as a number of cancer trusts in the UK. So everything around those appointments and everything around that, that's what the patient interrogates, and that's where the answer comes out. So it doesn't hallucinate or come out with spurious answers. It just comes out with the facts. And if it can't answer it, then it notifies the medical admin, and medical admin can turn off ISA and take over the WhatsApp or take over the messenger call or texting, and they can respond then to the person.
Neill, we very much appreciate your time today. Where can folks learn more if they want to, follow what you guys are doing, and when the paper comes out, where can they visit you?
So if they want to visit us on www.spryt.com, you find all the information there. You can also check out, we have a demo on there as well that's very self-explanatory, and anybody can watch it. And then, as well as what we're doing with our product and where we'll be going over the next couple of months and years.
Again, Neill, thank you for your time. We appreciate it. We're excited about what you guys are working on. Let's check back in 6 months or a year, and we'll see how it's going.
Thanks, Mike.
Good to chat to you. Take care.
Good luck. Bye-bye.